All right, everyone. Welcome to our journal club today. We are going to be discussing penicillin allergy. It's something that we deal with on a fairly regular basis in clinical practice, whether it be in the ambulatory setting or the inpatient setting, where patients report a penicillin allergy, and then that has an impact on how we prescribe antibiotics or how we approach that patient clinically when it comes to their possible infection that we're dealing with. And so with that, I thought it would be pertinent for us to look at what the update in literature is, because there are new studies that come out from time to time regarding penicillin allergies, what the cost impact is, what the cross-sensitivity is from one antibiotic to the next antibiotic. So with such a large number of patients reporting a penicillin allergy, actually, David, how many patients do report a penicillin allergy?
In the United States, there's about 30 million patients that report to their healthcare team that they have a penicillin allergy. It's the most commonly reported allergy noted in all the medical records, and it's very commonly overreported, and many of the patients don't actually exhibit a true allergy. A true allergy is an allergy it's through the immune system, and so there's 4 different types of immune reactions. There's type 1, which is your anaphylaxis, which can lead to hives, shortness of breath, and tightening of the throat. Those are your most serious ones. It's also an immediate response, can occur within less than 72 hours. And then there's also it's mediated through the immunoglobulin E, and none of the other reactions are mediated through that antibody, or immunoglobulin. There's also the type 2, 3, and 4 reactions, and then there's idiopathic reactions, which is sometimes referred to as type 5. And the type 2, 3, and 4, and then the idiopathic reactions usually occur after 72 hours, and they are not mediated through the IgE. So those are not the serious reactions. Sometimes like contact dermatitis or like a mild rash, not the anaphylaxis and the full body rash that sometimes occurs with type 1 reactions.
Okay. So you said there's a large amount of patients that present with a penicillin allergy. Do you have any numbers on what that number is?
Yeah, there was a study done by Fox and colleagues, and it was just looking at 638 patients that were, of those, only 19 had a positive skin test for penicillin allergy. And of those, there was 5 that tested positive that didn't have any indication for an actual allergy, and there was 14 that tested positive that had a history of penicillin allergy. But of those 14, 13 of them had indication for a serious allergy, which would be your type 1 reactions, and only 1 had a vague history. So that's indicating that the patients that had the more serious side effects and can report those side effects to their physician, those are the patients that really have the true allergy, and all the other ones might have just an adverse drug reaction in the past, and then they might report that as an allergy when it really isn't.
Okay. So the things that they identified as having the biggest impact were kind of this definitive history of a penicillin allergy, which would be the urticarial reaction or the anaphylaxis, and as well as that time period within 72 hours, most likely, which would be most indicative of type 1 allergy where we would have concern. Yeah. Good. I think there's another study that show about 10% of all patients will report a penicillin allergy, and then of those 10%, only 10% then are positive for a skin test. So really what we're dealing with is about 1% of the population that have a true penicillin IgE-mediated reaction. So definitely we've got a good number of patients that are presenting with this penicillin allergy, but then what we're seeing here is that we really only need to have concern for these patients that have the IgE-mediated reaction. So what kind of effect does avoidance of other beta-lactam antibiotics have on the healthcare system, or what does this penicillin allergy have in the healthcare system.
Yeah, so the largest effect that we see of the incorrectly reported is the use of broad-spectrum antibiotics. So with that comes two negative things. We have negative financial and negative clinical outcomes. So Macy and Contreras conducted a study that they looked at antibiotic use in a variety of hospitals in their area, and they did that over 2010 to 2012. And they looked at a total of 150,000 patients. And they split them into two groups. They split them into if they had a history of a penicillin allergy or if they did not. And what they found was that the overall use of antibiotics was about the same. They didn't find much difference there, but the use of broad spectrum was much higher if they had a history of a penicillin allergy. Some examples they found were fluoroquinolones, vancomycin, the third generation, cephalosporins, and clindamycin. And they found two negative clinical outcomes associated with that. They found increased risk of infection and an increased hospital stay. So they looked at three infections. They looked at C. diff, MRSA, and also the VRE. And patients with a history of penicillin allergy had a 23.4% increase in C. diff, a 30% increase in VRE, and over a 14% increase in MRSA. They also found increased hospital stays. So on average, they found that if you had a penicillin allergy, you were in the hospital for about 0.59 days longer, which was about a 10% longer stay. And they thought that maybe that's not clinically significant to be in the hospital an extra half a day or so, but financially it was a pretty large burden. So they found just in their patients alone, it added cost of $64.6 million. So pretty high number there. And then they also looked at the financial impact on an outpatient basis. And so McLaughlin and colleagues, they looked at patients with the beta-lactam allergy at outpatient university clinic. And they compared the cost of if they had an allergy, the cost of the antibiotic that they received on the outpatient side. So there's about a $10 difference if you had a history of a penicillin allergy, so a $10 higher cost than the antibiotic. And it doesn't sound like a lot, but the New England Journal of Medicine said that in 2010 there was 258 million courses of antibiotics prescribed just on the outpatient basis, so that $10 adds up pretty quickly.
Sure. Yeah, so if we say that 10% of patients reported penicillin allergy, and those 10% pay $10 more per prescription, that's 25 million times 10. We're back up to $250 million impact then. So definitely a big financial burden. And then as we see these increases in resistant pathogen, that obviously is going to require longer hospital stay or a larger impact on patients' mortality and morbidity. So definitely huge benefit impacts from the report of a penicillin allergy. That's great. Great data, thanks. So we're using broader spectrum antibiotics. We are avoiding beta-lactam antibiotics as a group because of this reported penicillin allergy, right? Is that what's going on?
Yeah, it's actually a common misconception that the allergy is due to the beta-lactam ring. So they think that cross-sensitivity, or it's thought that it's in the beta-lactam ring, but that's actually not true. So penicillins and cephalosporins have that ring, but that's not the problem. It's the side chain, specifically the R1 side chain. And the only cephalosporins that share that with the penicillins is the first generation and second generation. Third generation and fourth generation have a different R1 side chain.
Okay. So if there's only a certain... So if it's just these first and second generation cephalosporins that potentially share this R1 reactive allergenist anyway, side chain, what kind of data do we have looking at penicillin to cephalosporin allergenicity? There we go.
So there's a study done by Delott and colleagues. It's done in a hospital, examined over 27,000 charts, and of those 27,000 patients, 606 had a history of penicillin allergy and then were administered a cephalosporin. And of those 606, when they were given the cephalosporin, only one of them actually had an adverse drug reaction, which is 0.17% of the patients that reported penicillin allergy actually had cross-sensitivity to the cephalosporin. In another study done by Goodman and colleagues, also done in a hospital, there's 413 patients that had a history of penicillin allergy and then were given cephalosporins before surgery, and of those, only one had a reaction to the cephalosporin, which is about 1/4%. And then a study done by Apter and colleagues, which was done in the community. It was a retrospective study. They looked at over 500,000 patients, and of those patients, they all had gotten a penicillin, and then within 60 days had received a cephalosporin. And there was 3,920 patients that had a reaction to the penicillin, and then when they were given the cephalosporin, only 43 of those 3,920 patients actually had a reaction to the cephalosporin, which is about a 1.09% cross-reactivity, which was the largest of the three. And then when you compiled all three, there was a total of 4,826 patients that were given a cephalosporin, and only 45 of them actually had a reaction to the cephalosporin that had a penicillin allergy, which is only a 0.91% cross-reactivity between the two classes of medications.
Wow. So I mean, I don't want to understate the importance of a penicillin allergy. If a patient has anaphylaxis or urticaria, that's a significant manifestation, but it certainly seems like there's this gross overestimation or gross avoidance of cephalosporins, of other beta-lactam antibiotics that may not be appropriate, that have impacts on overutilization of broad-spectrum antibiotics, on increased healthcare costs, both from the inpatient setting and the outpatient setting. Is there anything clinically we as pharmacists or we as healthcare providers can do to help differentiate these patients or to avoid some of these ill effects?
Yeah, there's a test that can be done. It's a skin test, and what they do is they actually inject a small amount of penicillin into the patient, and then they look for IgE mediated response to that. So it's a really easy test. Penicillin is the easiest allergen to do the test with. It's fairly inexpensive, definitely more cost effective than the additional treatment and the additional use of more expensive antibiotics. Of all the patients that had a history of penicillin allergy, only about 2% actually end up testing positive. So of all the patients that report the allergy to their healthcare providers, when the test is actually performed, it's less than 2% of the patients have it. And the problem is there's less than 0.1% of all the patients with the allergy actually get the test done. So it's like a really underutilized test that could save a lot of money by using the test. But we're really looking for that IgE-mediated response, because that's going to be your type 1 anaphylactic immune response, which is going to be the most significant life-threatening response to the medication.
Yeah, so I mean, it seems easy enough to do this test, but only 0.1% of patients are getting this
0.1,
test.
less than 0.1.
What's the cost on this, or just is this feasible?
Yeah.
Is there a benefit?
So the same study that looked at the increased infections and the increased hospital stays also looked at the cost. They found it to be about $130 a patient to do the skin testing, which may sound like a lot up front, but when you consider for all their patients just in that study, it would be about $6.8 million to do the skin test. But also they found you would save $64.8 million in inpatient stays, and then you consider, like David mentioned, the increased infection, the increased antibiotic costs, and you can put all those costs together, and it shows that it's probably warranted. So.
Okay. Well, this is a lot of great information that maybe some of our viewers or listeners today weren't aware of. Definitely some things that I hadn't thought about in terms of the penicillin skin testing, but I guess our takeaway points here are that penicillin allergy, we're going to come across it as a report, but certainly there's going to be a low percentage of those that are truly penicillin allergic based upon a penicillin skin test. The report of the penicillin allergy increases risk for resistant pathogens, increases healthcare costs. Some of the things we can do to avoid or to differentiate a true penicillin allergy versus a non-true penicillin allergy is ask the patient what their reaction was. Did they have urticaria? Did they have anaphylaxis? Did it occur within 72 hours of administration of the penicillin antibiotic? And those would start to give us some indicators. And then if it seems like, yes, those are all yeses, then do a penicillin skin test to really differentiate those patients out. Okay. Alana, do you have anything on whether or not, like, there's differences in the formulations of penicillins, like throughout the year, or cephalosporins throughout the decades that may also be worthy to ask, like, when did they have this reaction?
Yeah, so before around the mid-1980s, when they made cephalosporins, they were coming from the same, and penicillins, they were kind of coming both from cephalosporins. So if they had it before they say mid-1980s, like 1985, there could show a cross-sensitivity. But since that time, they kind of derived them from two different molds. So that could indicate when they had it as well.
Okay. All right. So also kind of get an idea of what's the timeline and when did this patient have the reaction. Great. And have they had any antibiotics since then? Those are all going to be good questions that we can utilize when speaking with the patient about their reported allergy as to whether or not they truly have a penicillin allergy. Wonderful. I think we've got a few people on the phone, a few people in the online session. Are there any questions from those that are joining us?
Yes.
Okay.
Okay. So how much is a pre-pen cost?
Yeah, that is the test
Okay.
that's done, and I think what we found it was about $130 to have the test done. I believe that was for the pre-pen skin test, which is I think the brand of the test that is performed. So it's about $130 per test.
Okay. And then about the skin test sensitivity, how would you rank it? Like high or low?
The skin test, it's the most rapid and sensitive and cost-effective test that can be done.
I think what I'm trying to ask is how likely is a patient who has a penicillin allergy,
Like what kind
the
of
positive
manifestation
response
would
be?
they?
Like, can you really rely on it?
Yeah. What kind of manifestation would they show in terms of when the injection is administered? So looking for that pin and wheel type reaction when they truly show the pin and wheel reaction, that would be positive for the penicillin skin allergy.
Yeah, the skin will, some edema will happen around the injection site, and then erythema as well, so it'll be raised up and red, and that indicates a positive result from the test.
Great. Good questions.
What about if a hospital can do skin tests?
Can they be performed in a hospital? Was that the question?
What I'm asking is, what if a hospital doesn't carry a pre-pan? How would you assess the patient's allergy?
You would just go through some of those verbal questioning that we discussed. So if they reported a rash versus an urticarial reaction, or did they report diarrhea as their penicillin allergy, you go through that kind of differential. What I found is if patients have urticaria, which is this profound full body flower type presentation of a skin reaction, they remember it. If they've had anaphylaxis, they remember it. So if they say, I don't know, I had some kind of penicillin allergy, usually that's one of those non-specific type presentations, which we talked about earlier, was less likely to have the penicillin skin test. And then when did it occur in therapy? Did it occur 7 or 8 days into therapy? That's not going to be a true IgE-mediated reaction. And how long ago was it? Was it back in the 1960s when grandma first started taking penicillins and she had a little bit of a rash associated with it because of the impurities of the first penicillin components? Then those are all going to be things that you can utilize as a practitioner to help you differentiate whether or not the patient truly has a penicillin allergy, and make a determination as to do I need to use some other broad spectrum antibiotic in place of, say, a cephalosporin. Utilize a third generation cephalosporin, which we've talked about, has less cross reactivity because it doesn't have that same R1 side chain. So in the absence of having that penicillin skin test, those are some things that you can utilize.
Okay. And then my last question, since you guys give so much data on all these journal clubs, what would you say the overall cross-sensitivity between penicillins and cephalosporins and penicillins and carbapenems?
So I found a number on the cephalosporin side. It looked at if they had a confirmed allergy versus if it was just like a reported and we didn't know. And they found that with confirmed, it was about 2.55%. And if it was just reported, it was only about a 1%. And that was with the cephalosporins and penicillins.
Okay.
Cool. Well, one of the things I failed to do initially was introduce everyone. So as we conclude, I will introduce everyone and say thank you to David Spiro, who's on rotation with me from UMKC School of Pharmacy in his final year, and Alana Yoder, who's also UMKC School of Pharmacy student in her final year on rotation with me. I'm Eric Wamwell, professor with UMKC's School of Pharmacy, and we appreciate you coming today and getting involved in the conversation and asking good questions, and hope that you took away some good information on addressing penicillin allergies. All right. So long.